what we did about our device assistance in Parkinson's disease. I will speak all about, we know what it means, Parkinson's disease. We know about what it is, non-motor and motor symptoms in Parkinson's disease. For us, it's very important to know what type of new treatment appear and how we manage. And in our patient with advanced Parkinson's disease, the device-assisted therapy with Levodopa, Carbidopa, and Entacapone intestinal gel is regarded as a viable therapeutic alternative. I will present some cases. In our clinic now, it's more than 12 cases of different ages diagnosed with advanced Parkinson's disease, who received a device-assisted therapy in the neurology clinic, the emergency county hospital, St. Andrew from Constanța, Romania. We will speak about the profile of our patient who can benefit from this therapy, and we will show what is happening, why some patient discontinued the therapy, and what was the results. About the patient profiles for device-assisted therapy, we have the patient with advanced Parkinson's disease, Levodopa responsive, with complication about the most principal complication. There are motor fluctuation with off periods and hyper or dyskinesia, despite of optimization of oral or patch therapy. Patient has severe symptoms enough to require initiation of advanced therapy. And when continuous administration of apomorphine are contraindicated or inappropriate. It's very important, there are no age limit, and there are included patients with mild dementia, and very important, the same patient with responsible relatives. It's important to be considered that the patient level of independence, social situation, relationship with the family, living condition, home caring patient with cognitive impairment. About our patient, it's very important to see there are a huge area of years between 53 and 82 years old, and with a PD duration between 4 till 15 years. We, in our emergency department, we have, like I say, 12 patients, 3 patients who stopped the treatment after 1 month and 2 months, respectively, because the family did not offer support to continue the treatment. The patient who discontinued therapy after the nasojejunal probe was fitted on titration, was initiation, showed a favorable response on the first day, but on the second day, the nasojejunal probe shifted and no longer showed a clinical response. Therefore, the patient did not continue. It should be noted that when titration is done on the nasojejunal probe, there is a risk that the probe may move, and the clinical response may be observed until the first hour after the probe is fitted. Worst cases is relative young person, 53 years old, Parkinson's disease stage 4 young year, with clinical onset on 2018, with comorbidities like hypertension, angina pectoris, sinus tachycardia, and depressive disorders. We have prior to this admission, we have the patient has a treatment with Levodopa, Carbidopa, Entacapone, 125 per day per tab 5 tab per day, pramipexole 3.5 per day, and 3 weeks before coming in our department, they try Apogo 5 milligrams subcutaneous 3-4 days times per day in off periods, but patient don't want to go with this drug because she has adverse reaction like hallucination and visual one, nausea and dizziness. About the motor, the patient has hypomimic face, has bradykinesia, global extrapyramidal rigidity, flexed posture, bilateral positive NOICA, postural instability, small step gait with bilateral support, with freezing phenomena. About non-motor, we have depression, lack of motivation, apathy, and sleep disorders. About functional state, we have ADLS score 3 points. We have UPDRS for 3 part 52 points. Like I said, the diagnosis is Parkinson's disease advanced stage because has 5 levodopa doses per day with 2 hours of off in 24 hours. But it's important the responses to levodopa therapy, and she has an inadequate control of motor fluctuation with combination therapy with drugs available for Parkinson's disease. Administration of apomorphine, like I said, without dissatisfactory response and with the occurrence of adverse reaction. We have, this patient has sufficiently severe symptoms with a major impact on the patient quality of life. Because of her age, 53, like I said, she needs for independence, for a social situation, for a relationship with family, and the presence of a trust and responsible caregiver like a spouse, her spouse, who can be trained in handling the pump and administer the treatment. About this patient, we make the patient preparation with CT, with X-rays, about lab tests, with ECG, with clinical UPDRS part 3 and ADLS score, with gastroenterology consultation, with anesthesia consultation, and we make the titration. The patient clinical response to the new treatment methods is monitored. The gel is administered using a temporary nasojejunal tube. The equivalent dose are calculated from oral therapy to Levodopa, Carbidopa, Entacapone device-assisted therapy. And on day 2 of admission, the nasojejunal tube is fitted without incident. We make the conversion. It means from levodopa oral to the gel. We have a total dose of 1,146 milligram. The correspondent of a volume of 6.25 milliliter. We have a morning dose of 125, like I said. And the continuous dose, we have 663 milligram. That it means on 60 hours days, 2 milliliter per hour, the continuous dose. We monitorize and we titrate, and we have a morning dose 6 milliliter after 1.5 the continuous, and we progressively go up to 2.2 milliliter with extra dose, who in first it was 0.5, 4.5, and after we have 1 milliliter dose. What we saw here, it's about our patient. You saw it's in very bad condition. She cannot move alone. She cannot make anything alone. This is in the first day with nasojejunal probe. It was in a very, very bad state with akinesia, mostly a complete akinesia, we make the PEG-G sound, and after 5 days, we have a morning dose of 9 milliliter with a continued dose of 2.5 and extra dose 1.2. And at discharge, we put in the night roticodine patch 2 milligrams, and because it has anxiety, a little depression, we let her with lorazepam 1 milligram per day. And because patient was in the best state without moving, in the hospitalization, make a thromboembolism pulmonar. And for this, after discharge, we put apixaban on her treatment general. About this patient, I said in the first it was on UPDRS 3 part 52, and on discharge you saw we have an ADLS score 7 points from 3 points, and UPDRS part 3 from 52 to 32, and after the best of the best was after 30 days after discharge, because there was a huge improvement of motor and non-motor symptoms. And you saw the ADLS score, it was 9 points, and UPDRS part 3 scored 12 points. You saw the image of our patient. She is totally independent with no period. It's impressive. This patient, it was motor complete and now with 0 periods.
Așa, așa. Vă așezați pe un scaun, vă așezați pe un scaunel.
She can move alone.
Vă ridicați.
Independent now.
Veniți spre mine. Perfect. Perfect. Ia, un zâmbet aici. Un zâmbet.
Big difference and is very happy.
Foarte bine.
Now she works in the garden and her life is quasi normal.
Ce pot să fac și eu? Mai mă odinesc la prânz? Puțin veni.
About another cases, because our case it was big problem. This is a patient 82 years old. Because I said the age is not a criteria for this device. This patient cannot move single. Is with huge tremor, unreposed tremor, postural tremor, and intestinal tremor, and she must have for movement the bilateral assistance. After
putem să facem așa?
After
să deschidem. Bun. Acum cu fiecare mână putem să facem așa?
You saw the bradykinesia bilateral. Here the onset was 15 years ago. And here the patient can move without support. Normal, she has rest tremor, but she is independent. She can do quotidian activities. I repeat, 82 years old patient.
Putem să întindem așa mâinile? Bun. Degetul pe vârful nasului de 3 ori pe fiecare mână.
Another patient it was a huge problem because it has a mild dementia with severe bradykinesia with more than 5 hours of movement in the day, with bilateral rigidity. He cannot move without support. You saw the bradykinesia bilateral, right more than left.
Bine. Picioarele putem să le ridicăm un pic? Pe rând. Bine. Să venim un pic la marginea patului, putem?
Nu m-a ajutat.
Yeah.
Also the difficulty to rise from the bed for the bed.
Bun.
Very clear the rigidity.
Mersi este numai cu căruțul?
Nu, merge încet.
Încet? Și merge și fără sprijin, adică fără să-l ajutăm?
Merge, dar nu tot timpul.
Nu tot timpul? Ia să vedem, să punem încet pe ce ei vă ajută că sunt aici. Ia să începem să-i punem. Ia să vedem mai.
And here, after discharge, it's independent. It cannot walk alone with a little freezing, but it's independent.
Dă un pic că și-l veți lua acela la o parte și fă din mâini cum face.
Another case, it's a relative young person, 52 years old, with a severe camptoformia, with bilateral rigidity, with bradykinesia, bilateral, with hypominication.
Și cu celălalt picior?
This is before.
Încrucișăm mâinile așa la piept. Și cealaltă mânuță. Și încercăm să ne ridicăm. Perfect. Haideți să facem câțiva pași, vă rog să veniți către...
This is after.
Bună ziua, cum vă numiți?
Abdulhamid Nidroan,
Și câți ani aveți?
60.
Bine, domnul Abdulhamid. Haideți să întindem mânuțele în față. Degetul pe vârful nasului.
So the improvement of mobility
Deschidem pumnii.
of the
Și cu
kinesia.
cealaltă. Acum așa. Da. Să ridicăm piciorul. Și cu celălalt. Așa. Și cu celălalt. Să încrucișăm mâinile așa, amândouă, să ne ridicăm de pe scaun. Haideți să încercăm. Foarte bine. Și haideți să mergem să facem câțiva pași. Putem să ieșim un pic și pe fol? Ca să vedem mai bine. Perfect.
Can walk without assistance.
Bun. Ne întoarcem. Bună ziua, cum vă numiți?
Abdulhamid.
Putem fără să ne sprijinim? Așa. Foarte bine. Îmi cer scuze dacă lovesc pe cineva mergând cu spatele.
Și acum să ne așezăm, vă rog.
Bine, doamna Chirea. Haideți să ne întoarcem.
O să vă rog să faceți așa ca...
Or with
Bine, mă bucur că vă întoarceți mult, mult mai bine.
Fără să lași mânuța singur, să vă dau merge.
the kinesia application after
Și cu celălalt.
the kinesia.
Așa? Bine?
Perfect. Ia uitați-vă la mine.
Încă o dată.
Da? Bun. Ducem vârful de pe vârful
The
nasului
patient who it was with
și cu cealaltă mână.
before the procedure with bilateral bradykinesia, right and more than left. With bilateral rigidity.
Ok. Putem să venim un pic la marginea patului, încet? Mânuțele puteți să le lăsați jos. Bun, poți să vrem să facem câțiva pași. Încet, încet.
Right, a little slow. You can walk, but with small steps, shift.
Bun. Vă întoarceți.
stability with tendons and movement.
Și o să vă rog să vă așezați un pic pe scaunul acesta din fața dumneavoastră. Așa. Perfect.
And here it's after the procedure.
Așa.
With
Acum așa.
of kinesia, with improvement of gait, but patient has here a problem because in the second day the tube, nasojejunal tube moved and the patient not feel well and he renounced to the procedure. He wants to think more about this procedure. Patient with Parkinson's disease, beside motor symptoms, suffer from multiple non-motor symptoms such as sleep disorders, psychiatric disorders, depression, anxiety, autonomic disorders like cardiovascular, urogenital, gastrointestinal, and cognitive dysfunction. And all of these non-motor symptoms are often associated with severe disability, with reduced quality of life for the patient and increased care for caregivers. In patients with Parkinson's disease, cognitive impairment is a common non-motor symptom. It has also observed that the incidence of dementia in people with Parkinson's disease is 4 or 6 times higher than in a healthy individual. And the majority of patients who lives more than 10 years develops symptoms of advanced cognitive impairment that have a negative impact on the performance of daily activities. Recent studies have highlighted that treatment with Levodopa, Carbidopa, and Entacapone intestinal gel has led to improved cognitive impairment in patients with advanced Parkinson's disease. Our conclusion was that continuous Levodopa administration has been shown to be very effective in reduction of interval off in patients with advanced Parkinson's disease who were not well controlled with oral Levodopa treatment or apomorphine administration. Patient quality of life improved significantly, and we speak about ADLS score that increased, UPDRS part 3 motor score that decreased. Also, we have an improvement in cognitive. About the aim of developing Levodopa, Carbidopa, and Entacapone administrated as intestinal gel was to improve the disponibility of Levodopa and thus allow a reduction in dose and possible decreased exposure to metabolism and degradation products of Levodopa, Carbidopa. Thank you very much.
Thank you very much for the very dramatic presentation. Do you have any questions from the audience, from our web audience? No. Myself, I am the director of disorder outpatient clinic here in Thessaloniki, and in Greece there is a commercial use of Carbidopa, Levodopa, and Entacapone, but we use Carbidopa, Levodopa, and I follow a group of 2 patients. We had some amazing several years in many of the patients. People assembling group patients that were devastated. They were fine with their beds. They had the opportunity to move and gain back their life. I was always eager to try new things and compare my results to what you've shown to my previous experience. I didn't get so good results when it came to tremor was more compared to bradykinesia and also I think that maybe Entacapone is going to add on my reach out also, not so it's not the strong point of
Levodopa.
So yes, I was really good. Hopefully we're going to but the new I know it's also it's smaller.
Yes, it's real. The pump is smaller. You saw it. Yeah, yes, similar, but it's a little bit bigger than that. Yeah, but it's different about the size. And what you said is true. It's the tremor and the biphasic dyskinesia. Yes, in the first one.
The only thing that bothers me with Entacapone as a drug, when it comes to elderly people with hallucinations and dementia, it's a problem. They can be a challenge. They can, in a way, cause more hallucinations than plain Levodopa. So if you encounter, I got to relate to the old
82.
lady. She was definitely intact, but I mean, somebody that is, in verge of developing a violent mental hallucinations. Do you feel that the Entacapone could be a problem?
It's possible to be in time because it's a new drug. We don't know in the future what it will be happening. But till now, I'm not say it. And for this, I tried on 82 years old. It was in my head. Yes, it's the same Entacapone for the visual hallucination. But till now, we not have any problem. But in the future, we don't know. Yeah.
Weight loss.
Yeah. We will see. The future.
Very promising.
Yeah.
Thank you so much. Yes, please.